Hello, hi from Switzerland to this online webinar with Dr. Alecsandru Ionescu from Romania. Hi, Alecsandru.
Hello.
My name is Holger Kast. I'm the head of training education at TRI Dental Implants here in Switzerland. I'm leading you through this webinar. There's certain rules for the webinar, so during the presentation you can always write questions into the question field on the right side in your toolbar of the GoToMeeting software, and I make sure that at the end of the presentation of Alex, we will pass all the questions to Alex, and then we can have a little question and answer session at the end of the presentation. Today's topic is a new approach in the digital world, tissue level implants without abutments. This is, I think, a very interesting topic. It is a little bit a combination of the technology of the implant and also the know-how of Alex. And so before I pass the word to Alex, I would like to introduce you a little bit about the TRI implant system and our philosophy. The TRI implant company is existing now. We have our 10 years in 2021. We are 10 years in the market so far. We fully have a 100% Swiss made implant system. I'm sitting right now on the beautiful lake of Zurich, directly in the head office in Zurich. The production site is not far away from here. We produce after our performance concept high quality implants since these 10 years and focus a lot of innovative developings and simplicity. This is the third point here. Simplicity is one of the goals of TRI. We have already in our existing implant system, which is a narrow a bone level system and a tissue level system, which Alecsandru is maybe, I always tell him he's the god for our implant system, but the simplicity in the system is really, we have a narrow bone and a tissue level implant system with one surgical kit, and we simplified our product portfolio for the prosthetics that much that we have really a very lean product portfolio, and that shows already simplicity. But in the last years, it's absolutely clear that TRI is focusing completely on the digital workflows, on digital components, on digital, think digital here, the last part, solutions for simple, fast, and cost-effective digital workflows in your daily business. So the last 10 years, we developed a lot of great things. We started in 2011 with the bone level system and with a narrow implant system. We were clear from the beginning on that digital components, which is we call it 3+, TRI plus components, and we have open interface. We have an open interface, so it's easy to create prosthetic on top of our implant abutments in this moment digitally. We are open here with an open interface, but then in 2014 already we developed a tissue level implant, our 3-octa implant system, which I want to focus here quickly because as I said, Alecsandru Ionescu, he is really showing the last years and performing amazing aesthetic implant placements with this unique tissue level implants with a pink anodized surface, and so this is really when our paths met each other, and since there we are working together with Alex mainly in the tissue level topics. But the last years we didn't sleep, and we created a lot of more great product components, unique great product components, like for the tissue level and bone level. We created tie bases because tie bases got more and more important due to materials like zirconia and CAD/CAM technologies. We had to add to our existing systems a tie base, which has a patent on it. It's a unique tie base because you can individualize it, and I think this is a really great product for the existing portfolio. In 2018, we created, and I think this is also the topic today, the both worlds. I know that Alecsandru is showing cases on the tissue level, on the existing tissue level implant system, and he shows the analog way of creating great prosthetics and into the digital world, and therefore we created an open tray impression pose which combines the two worlds, because it's also an intraoral or extraoral scan body as well. So two products in one product, and then we focused the last years completely on our digital implant, the matrix implant. And the matrix, we get already the CE in 2020, and we have the big final launch on the 18th of June this year, which I will explain a little bit more for this special event, where I really would like that everybody of you listening here today is signing up for this special event. But the topic today is really tissue level, and so this is more or less the way of tissue level. So this is the old tissue level, or the existing tissue level, and this will be the new tissue level, where it's the last part of Alecsandru's presentation today, a tissue level where you don't need an abutment anymore. So how is it possible? The matrix implant, the world's first digital implant, approved for digital restorations without abutments. We eliminate the abutments, we eliminate the cementation, and we have created an implant with this. And it's not only a tissue level implant in the portfolio, will be also a bone level implant, but the implant connection, which you can see here, allows you to eliminate cement and abutments. We have no limits here anymore. All in this is with 8 patents, unique patents. So with TRI and this digital implant for the next 20 years, we really created here something the world didn't know so far. So how is this possible? What was the idea behind this, and what did you do? So for us, from TRI, from the developing, it was always clear that between the CAD/CAM technologies, which are new technologies in the markets, which entered the market the last, let's say, 10 years, the CAD/CAM technologies, also materials like zirconia, entered the implants market. And there's one thing which did not change so far, and this is the implants. The implant connection were all not created in a time, octagon connections or Morse taper connection, really steep connection. All these connections were created in a time where there were no CAD/CAM technology involved, and also no zirconia was involved. So the materials were not sorry, I stopped one step too far. So there's a mismatch between these materials and also the technology which we can use in our days. And so in our days we have created a solution for this, and all the implant industries use tie bases to match more or less the connection of implants, the existing connection of implant, with these new materials like zirconia and CAD/CAM technologies. But the tie bases itself, they still have limits, for example, in aesthetic reasons. So you still can see a metal frame, because you have to have, as you can see here, we call it, by the way, crutches, because it's really a helping part between the zirconia materials and that connections. And so we have here still a metal frame which is not really aesthetically. We still have the risk of inflammation. So the cementation is not really it's poison more or less for the bone. We can even have a debonding of cementation. So that's really some things which are not really perfectly, and that's why we created this matrix implant connection, which I explain you quickly. I just show you one quick picture of a study we are doing with the university, or we did with the university in Zurich. We compared different tissue level implants. This is on the right side, you can see the matrix implant connection, the tissue level implant, and here on the left side, a random tissue level implant with a tie base. And already everybody of you can understand that aesthetically this is already here much higher. We can have a white colored zirconia implant, teeth color into the implant with this matrix connection. More about these studies and this outcome on the 18th of June at our big event, online event our special event for the launch of the matrix implant connection. This is the tissue level matrix implant. Just quickly from the outside, you can see already a very difference to random implant, tissue level implants. We have the pink anodized, we have a concave design, and the inner connection. And this is also, I cannot explain you in this presentation too much of the details, but you can see we eliminated the abutment, so we gained more space in the inner connection, and we have a very smooth and wide and flat base here created. So it's absolutely possible to mill the inner connection with the certain milling strategies, with the TRI milling strategies, on a perfect fitting into the inner connection of this implant, of the matrix connection. We can mill directly zirconia into this inner connection. How does it look quickly? This is just a milled full zirconia monolithic crown. And you can see, I think pictures show more than words can say. You can see this perfect fitting on the implant analog already here after milling. This is possible to mill with a standard CAD/CAM, even chairside milling machine. You are able to create with in combination with a milling strategy from TRI, you can create a perfect fitting here. And just for my last picture, I would like to show you here this perfect connection milled. This connection is milled by a milling strategy. It gives you the perfect fit on matrix connection and perfect stability as well. Comparing with a standard tie base, actually, this is a zoom into our tie base. This is really the 45-degree shoulder, and you can see here on the surface of comparing the surfaces here how what is possible with a standard milling machine in our days, and this allows you the fully digital workflow in your daily business in combination with your dental technician. And so, but enough for my words. We have really since the last September, since we have this matrix in a key opinion leader phase, we have almost placed more than 1,000 matrix implants all around the globe. And one KOL of this is Alecsandru Ionescu from Romania. You can see here on this picture, we can create with this new technology, we can create chairside healing colors, healing abutments created with a milling machine just on an immediate placement. Fully aesthetically, we can even go with this matrix implant connection to full arches. Because of the inner design here, we are able to have angulated implants up to 100 degrees, and we can create chairside PMMA temporaries, for example, with an intraoral scan. But all this and more details of different cases we did, we will show you on the special event on our world premiere on the launch of the matrix implant on June 18th. I will tell you a lot more details who is going to be a speaker on this event at the end of the presentation, but from my side I would like to pass the word right now to Alecsandru. Please, Alecsandru, I will make you as a moderator. Go ahead, introduce yourself. I'm looking forward for a very interesting presentation.
Okay, thank you very much for your invitation, and also thank you for creating this this opportunity for showing some ideas about the matrix. Just a second to organize my screen. Good. Okay, I think now the presentation already is online. Yeah. Okay. Just a quick. Good. Okay. So I started my work 20 years ago in Bucharest, Romania, and now I'm splitting my passion for aesthetic dentistry with my team. I have 2 offices in Bucharest, a team of almost 30 people that supports me in order to have, let's say, happy patients and beautiful cases, and also in order to be able to get in these studies that we are doing. I'm going to talk today about my main approach in implant dentistry, the use of tissue level implants. And also I'm going to share with you the story how I was convinced to switch from an analog approach to a digital approach. So we are going to talk about the tissue level implants in the analog era, and I'm going to show you how did we use to organize these cases before, how I get to the transition from analog to digital, and now in the last period we started using this matrix tissue level implant that pretty much changed the entire philosophy in treating the patients. So let me begin with a simple question. What is your implant selection strategy? Because it's very important nowadays to make sure how you are going to offer to your patients the treatment. So it's brand oriented or maybe cost oriented, or also it's important to take a look in the research history of the implant. So how do you describe this implant? This is very often used in Romania. It's a bone level implant. And now what about the concept oriented? We decided to go on with just a concept of tissue level implants because of their, let's say, similarity to the natural dentition and to the respect of the biological width in comparison to a bone level. Now, today, we can put all the advantages of the tissue level implant and the concept of biological width in the prosthetic treatment on tissue level implants with a new matrix tissue level implant, which eliminates, as Holger said, eliminates the use of cement or the use of titanium bases when you have a screw retain. So I'm going to show my experience and how did we change from analog to digital. So let me start a little bit with how we did the implant strategy before going to digital. So it's just another case done with a 3-octa tissue level implant. The simple case that we used to have. All the time we prepare the case in a backward planning manner. So even at that time, we used to have that wax ups, and we used to place the implant as close as possible to the future crown position. So the tissue punch. And okay, how safe is flapless today? Today we use the surgical guides, and we created a much safer approach. But in terms of patient comfort and post-operative pain and swelling, this is the strategy that fits very much the patients, the flapless approach. So the tissue punch, as I said, we have the biological drilling in our concept. It's something that we learned from Professor Anitua from Spain. We use a low speed, 100 rotations per minute without irrigation, and we can also collect the bone when necessary. And this was the position check that used to do when we did it as a freehand approach. Okay, how safe was it? As you can see, we were exactly in the position of the implants, and you can see how did we start. So we had to extract these teeth, the open healing, flapless socket preservation approach, and then 2 years after loading. So this is a sequence. I'm not going to insist on open healing, but it's one of my, let's say, main topics, and also a lot of study that we did with this flapless approach in minor bone augmentations and socket preservation. And this is the case after 2 years. As you can see, we had a full zirconia crowns that were cemented directly on the tissue level implants. So at that time, there were not so many alternatives in terms of colors, so you can easily identify the full zirconia crowns that were done 7 years ago. But as you can see, there is no gap, no micro gap between the connection, the crown and the implant shoulder. And again, 5 years follow-up, and you can see how the papillae are present there. There is an interproximal papilla stability due to the respect of the rule that was described by Dennis Tarnow, that we need to have no more than 5 millimeters from the contact point to the bone, such as we can preserve the papilla in a biological manner. And a close-up with this case after 5 years. And here you can see the 5-year Cbcd scan and the stability. It is important to understand that for tissue level implant, the most important advantage was the fact that it was possible to cement the crown directly to the implant shoulder. And then we started having problems with the cementation, as people know, and then this is how the titanium basis occurred. And when you see the matrix, it's going to be the elimination both of the cement and the titanium color. I will show you the sketch for that. Now, 7 years follow-up, and again you can see the stability of these tissue level implants, both in on the X-ray and the clinical on the clinical pictures. So this is why we are using for 14 years exclusively tissue level implants, because of their simplicity and the biological concept that can be respected for long-term stability. Just a short comparison between a tissue level implant and a natural dentition that was published by Anthony Sklar back in 2003. And some information from one of our studies regarding the comfort that the patient received, felt after tissue level implants in a flapless manner. As you can see, we had a very, very good outcome. Now, what is your treatment approach today? We need to be very, very precise in terms of a treatment plan, in terms of surgical protocols, and of course in terms of prosthetic protocols. And as we know, nowadays dentistry is somehow guided by the prosthetic concepts. This can be done, of course, in an analog way, but now lately we do it in a digital way. I was very skeptic a few years ago with let's say digitalization of all the dental approaches, but since I started 3 years ago, a little bit of digital here, a little bit of digital there, and after about 1 year we decided to go on with digital in as many aspects as we could. So one more very important issue with everyday implant placement: shall we do it immediate or shall we do it delayed? With the analog way of thinking, we had a lot of problems for restoring immediately, taking impression and things like that. Now with the digital protocols, we have a very, very simple way to get this done. So I'm going to show you also an older case. We had a problem in the right upper central incisor. We had to extract it. Here you can see again the open healing concept. It's an alteration of the ice cream cone technique. So we fulfill the gap, and then we do not touch the periosteum, and then everything it's protected by a collagen membrane that is going to resorb and will generate the preservation of fixed gingiva, as you will see. So everything is done in a flapless manner. And here you can see the healing after 6 months. Of course, we had to retreat the other central incisor. Here is the flapless insertion and the right positioning. And the old-fashioned way of cementing crowns on the implant neck, similar to the natural dentition. So you can see here, a classic way of restoring a tissue level implant. And here you can see the evolution and how the papilla is going to, let's say, regenerate and stabilize in 3 years' time. And also palatal view, as you can see, we respected the anterior guidance, both on implant and the natural dentition. You can see the marks of the impression paper. And the close-up after 3 years of the crown that was cemented directly on the implant shoulder. And you can see the texture of the fixed gingiva that was never touched in terms of flap or anything else. But in 2018, later on, we had a surprise. The patient had an accident and he broke the other central incisor, where we were able, fortunately, to place another tissue level implant immediately. And you can see the sequences after the placement and the positioning of the abutment. And with the same strategy, we cemented the crown directly on the implant neck. Here you can see a Cbcd scan on the left side of your screen. It's the first part of the case with the upper right central incisor, and the evolution before extracting. There was no buccal bone. You can see with the open healing concept how was the generation of the bone. And then with the flapless approach, you can see the stability of the marginal bone in the buccal side. And the same on the right side with the other part of the case, where we were able to immediately place the implant and the stability of the buccal bone as we did it in a flapless manner. And this was the restoration. And at that time in 2018, we already started with our digital approaches, and it was something that we didn't like, of course, about the case. And then we decided to, after we cemented the crown, the new crown, we decided to take it away and redo it in a digital way. And what we did, we scanned, we copied, pasted the other existing central incisor, and we decided that we will need some non-prepped veneer on the lateral incisor in order to create the right aesthetics on the case. And here you can see, after we used a little bit the digital approach in our prosthetic part, how we cemented both the crowns on two adjacent tissue level implants in the aesthetic zone. And you can see the stability that we obtained from that. And here is the X-ray, and you can see one of the crown was layered ceramic over the zirconia, and the other one, as we just copied it, it's full monolithic, and you can see how nice the full monolithic, and you can also see that the non-prep veneer is almost invisible. So we can respect the biology and the aesthetics. So, as I said, biology and logics generates the biologic approach. And here you can see a comparison between the position of a bone level implant and a tissue level implant. And now this is the latest matrix tissue level implants that I'm going to show in terms of how we can have the same advantages from the old tissue level implant with the cemented crowns. Now we have this on direct restorations inside the implant without any abutment, and you will see right away. We also had another study that we did in our office. We had a comparison between the tissue level implant and the bone level implants, and we can see how the bone level implants are affecting the bone, the cortical bone around the neck of the implant, compared with the tissue level implants, where the connection is 2 millimeters away from the bone and the strength is going directly on that part. Now a little bit about our transition. I'm going to show you a case that was done fully digital. So this is the initial situation and final CBCT after implant insertion. So we had to scan, we had to plan backward the crown, and we created the surgical guide. For this case, we had to do a little bone splitting. You will see this is a surgical guide creation. So everything was done with Implant Studio from 3Shape, and we have a full digital approach with the TRI soft tissue level implants for this case. So this is a planning and a surgical guide creation. And again, where we started, and you can see how we enlarged the bone, such as we have buccal bone on the threads. Clinical view with a surgical guide. We used the surgical guide for the first drill, then we are successfully using in this type of cases a mixture between the Versa burrs that you probably know, Versa drills, and minimally invasive piezo surgery approach that we are doing. And here you can see the case. I will not insist about the surgery. I will just insist about the fact that we did, the entire case was done in a full digital approach. And this is the crown creation. We respected the initial digital wax-up that we had. And then we had a new scan, and we used the initial wax-up that we created. And we just printed the model for showing at the courses. So this basically was just to support the idea that we did it in a very precise, in a totally digital way. So the model was just didn't need it. We just used it to be able to show this type of connection and adaptability to in this type of courses. So we have a very good implant stability that we use with Ostel. You can see 84, both mesodistal and buccally lingual, and how healthy the tissue level around the tissue, soft tissue around the tissue level implant looks like. And here you can see the final restoration in a screw retained way. Now, compared with the cemented crowns, there is a very, very thin collar that it's visible here on the X-ray. You can see it. There is a small, very, very small collar from the 3 titanium base. 3 titanium base for the tissue level implant is the thinnest available on the market. So I'm going to show you a difference between this type of titanium bases. Now, this is the connection for the matrix. And this is where the prosthetic restoration is going to be fitted. And I'm going to leave you with a few short movies showing the surgery of a case, and then I'm going to explain the advantages of using this matrix connection. So atraumatic extraction is very important. We need to preserve the bone all the time. Drilling done through the surgical guide we only use the first drill through the guide. Then we use these versa burrs to condense the bone in the new alveolar. And then this is, you can see the tissue level matrix that is inserted. Now we are fulfilling the gaps with BIOS. When we have less than 3-4 millimeters of gap, we can use cyanoacrylate over the BIOS. Otherwise, as you can see here, we are placing a small resorbable membrane. Everything is done in a flapless manner. You can see there was no incision of the periosteum. Now the same patient, the same day, we had to deal with the lower part as well. The same, let's say, way of atraumatic extraction without destroying the bone. We will need a slight incision on the crest because we will fulfill with biomaterials in order to be able to use the immediate implant placement of the tissue level matrix. This case was done with a narrow tissue level matrix. It was actually our first case with a narrow tissue level matrix. You can see we used the surgical guide for initial drilling. Again, the versa drills for condensing the bone inside the new alveolar. Then we had some cortical that we had to taper, verifying the bone level margins. And this is the 3 matrix tissue level narrow implant. Again, the open healing concept. So basically, we fulfill a gap with a BIOS, and then we use the collagen membrane, the BioGuide, to protect in an open healing manner the gap between the implants where we had to fulfill with biomaterial. We prepared the membrane before, then we fulfill the gap, and the tissue level implants will basically integrate the bone, and we will never re-enter at the level of the bone. So we will just go on. This is one of the most greatest advantages of the tissue level implants. Basically, that we never give any stress to the connection between the bone and the tissue at that site, having at least 2 millimeters away from the bone. And you can see there was no deforestation on the buccal bone or the lingual bone, and we do not try to close the wound. So we just leave it to heal as secondary intention in this open healing manner. And here is the Cbcd scan before, and you can see the Cbcd scan after the surgery, and you can see the BIOS granules that are fulfilling the gap and also you can see the level of the tissue level implant. And here on the lower side, again, before implant placement on the right incisor, and after, and now on the left incisor, and here you can see how it looks after the implant placement. It was slight, let's say, level difference between the two implants because of the condition that we had, but with a matrix that we can create a direct connection regardless the depth of the connection, it will be possible to compensate this. And here you can see we scanned intraorally during the surgery before finishing the bone augmentation, both upper and lower, with dedicated scan bodies for the matrix. And this is the result. And here you can see how we did the same day provisional design. Of course, it's not the happiest case in terms of aesthetics and function, but we were able to restore in one day the design, and you will see now the exact emergence profile that we had. And here is the connection that you can see. Basically, there is only the screw and the restoration that is going inside the implant. And considering that the implant is a tissue level implant, then basically it's the most biological way of and ideal way to treat a case. And you will see also on the lower side, this we had to adapt intraoral, the mucosal part of the ridge, where basically we scanned before having the BIOS and the BioGuide placed there, and it was a little bit too long, and this we just adapt it, take it out and adapt it in order to protect the surgery. So we will be able to develop this type of discussions about this concept in our meeting that is going to take place in Zurich on the 18th of June. And now I'm showing you a short handmade sketch that I did last night around 3 a.m. In order to be able to clarify the advantages of the tissue level implant. So in the first sketch, you can see a classic tissue level implant with a classic inner abutment and the crown that is cemented directly on the implant shoulder. On the second image, you can see the same classic implant with a titanium base that is usually too thick for aesthetic reasons, is too thick, and also for let's say biological reasons is sometimes too thick. And if the dental technician is not very attentive and it's blasting by mistake that color, then this can become a rough surface that will add a very let's say a very rough surface to the friendly to the bacteria around. On the third image, you can see TRI titanium base, which is the thinnest on the market, as I said. So it was the best screw retained option before the matrix implant occurred. So before matrix, we were dealing with cemented crowns directly on the implant shoulder, but we had to be very, very careful not to have cement around where the soft tissue was thick, and the crown was more than 0.5 under the gingival margin. And then we preferred only the TRI tie base because it was very, very thin. Now, with a new implant and the new connection of the matrix, we can have the ideal situation from a biological point of view that we had in the cemented crowns on the implant shoulder, but without any cement, because we basically have the same situation. We fix the crown, but directly on the implant shoulder without any intermediate connection. That any intermediate connection between the implant and the prosthetic restoration, it's bad for the surrounding tissues. And this is why in the bone level implants there were so many peri-implantitis cases, because of these double gaps between the implant and the abutment, and the abutment, the crown on the other side. So now we are able to obtain all the advantages that we had in the cemented crowns with the screw retained crown directly on the implant. And our last case for today, it was a 70 years old patient when he first came to solve these problems on the left upper quadrant. And you will see here that he lost a lot of bone, and we were thinking of a vertical augmentation combined with our open healing concept, in order to be able to preserve the surrounding 3D architecture, such as we can afterwards flapless inserts to implants in the region. So what we did was we extracted, automatically of course, with bone preservation, the teeth, and we fixed. So the only deprioritization was for 1.5 millimeters to be able to insert some pins in the holes of the titanium membrane. And this titanium membrane was a confirmator of our open healing approach. So we placed the titanium membrane mesh over the BIOS, and then we placed the BioGuide, and we left it healing open. And you are going to see how it's healed after 2 days, 7 days, and 3 weeks. The success key here is to make sure that the titanium mesh is not moving during the healing period. Otherwise, you need to take it out. And again, 1 month and 6 months follow-up, you can see before taking it out at 6 months, there are some small part of the mesh that were penetrating the fixed gingiva, but otherwise we had a very nice thick gingiva. Imagine any other type of procedure where we would have done a flap or anything else would have been necessary to do a second surgery for a vestibuloplasty. But for this flapless approach, this is not the case. So this is where we started, an X-ray after we finished with a BIOS and the titanium mesh. And here is where we took out, after 6 months, the mesh, and very quick healing. In 1 week time, we were able to insert the tissue level implants in a flapless way. And also, this is a case where we had a pontic and we cemented it. So in this type of case, with the matrix implant, we wouldn't have any problems in taking out the excess of cement, because there were more than 0.5 millimeters of the neck and soft tissue. And here is the case, the X-ray before and after. We did an internal sinus lifting on the molar implant, and you can see the TRI octa and the level of the bone that we preserved and maintained it with that flapless approach. And here is a clinical situation and an X-ray after the cementation. Here is a part of CBCT. This is why it looks blurred, but you can see that after two more years, the soft tissue is stable, and you can see a Cbcd scan after 2 years, and you can see the level of the bone. You can easily see the BIOS, and you can easily see that from the threads of the tissue level implant, we did not lose any bone at all. Again, 1 more year follow-up, and again the X-ray in 2017, and a 5 years follow-up in 2019, and you can see the stability of the bone and the stability of the tissue level implant. We have a small chipping on the molar, but we just decided to leave it as it was, considering that the bone tip was cemented. It was not a case to replace it. Now, after 6 years, the patient came for the regular checkup, and we saw that the nearby premolar was in trouble. We had mobility and pain in the axis of the tooth, and we decided to take it out. And for this case, we decided to go on with the digital approach. What we did, we scanned the case before to have the exact profile and design of the natural tooth, and then we decided to immediately insert tissue level matrix implant. When we have problems with roots, in order to preserve the bone, we used piezo surgery. And now you can see the first drilling through the guide, again the Versa drills, and on the right side you can see the tissue level implant matrix and its connection. Here we inserted, so the insertion of the implant is done freehand. We only have the first drill that we do it guided, and then the rest of the sequences are done in a freehand manner with the Versa drills to be able to preserve and condense the bone when is the case. And now TRI is working on the full digital sequence approach with a full digital guide. So we will, when it will be available, we will be able to use it. And here you can see there is a gap between the implant and the alveolar, and this gap was fulfilled partially. So the buccal part, we placed a membrane, and in the palatal part, because it was less than 2 millimeters, we just applied a thin layer of cyanoacrylate. And here is the short movie of the surgery. Here we check the guide. We do the first drills through the guide. Then the Versa drills, which are unbelievable in terms of success. Then we find the right position of the implant, and then we insert the implant in a freehand manner. We double check the torque with the manual ratchet. We fulfill the gap. And before placing the membrane, we scan, as we did in the previous case, but I did not show this detail. After we scan, we place the membrane, we suture. We always use the PTFE sutures all the time for all their advantages. And we place the cyanoacrylate layer on the palate. So after that, we prepared a personalized healing abutment that we were able to use. This is the intraoral scan before surgery. And after the implant placement, and also before placing the membrane. And here is how we created the personalized healing abutment exactly with the emergence profile of the natural dentition. So we replicated the emergence profile. We cut it half. So it was like an immediate loading with a half a tooth or something like that. And this is the connection and the shape of the personalized healing abutment. And it's the exact replica of the natural tooth. And here you can see the CBCD after implant insertion. It is still with a standard healing abutment. We had to produce, we needed a few hours to produce the personalized healing abutment. And this is how it looked with the healing abutment. As you can see, we had a very nice tissue situation around the new implant plate with a customized healing abutment. Now, it was the same when we created the definitive crown. We were able to copy the initial natural dentition, as you can see. And of course, we improved a little bit the contact point, but we had the texture and the emergence profile of the natural dentition. And it was very nice that we created the design in Bucharest, and we sent the design to a TRI partner in Portugal. And in 3 days, we had the full monolithic crown that was done in that TRI laboratory partner in Portugal. And it was just perfect, with a perfect adaptation. There was no need for us to do anything. So they 100% respected the design that we sent, and everything was perfect in terms of fitting on the implant. And here is the final restoration, and you can see how nice the crown on the X-ray is adapting directly on the implant shoulder. And you can see that the nearby implant is the classic tissue level implant with a cemented crown. So basically, here are the best, let's say, alternatives for a biological restoration with the matrix and with a cemented crown on a old tissue level implant. So basically, we were able to obtain the same advantages without cement, which I think it's huge for nowadays dentistry. And here is the crown no abutment, no cement, and this was the final design that we got from Portugal. We just stained it a little bit to be in the same stains of the patients, but everything else was just perfect. So now we are still able to control the digital world. We hope that the digital world will not control our brain, but we need to take as much as we can from the digital protocols, but still be able to think biologically and let's say be able to think how we learned about the true medical approaches in the biological approach. So thank you very much for your attention. And here's my email address if anyone wants to contact me for any minimally invasive reason. And I hope to see you either live or in a hybrid way in Zurich in June. Thank you very much.
Thank you very much, Alecsandru. It was a really impressive presentation. Really, as you promised, from analog to the fully digital workflow, and as well as from abutments to no usage of abutments anymore. Thank you. Thanks a lot. It was clear that we got quite some questions here, and I try to settle these questions. I think I start maybe with the question here regarding this one. I think it was bone splitting case with the mesh. Which soft artificial bone under the titanium mesh did you use? And the next question in this, and the membrane as well. It's extraordinary. That came from Germany.
Thank you. I use BioOS, small granules, and BioGuide, and I'm working for almost 10 years with this biomaterials, since we started with this biological approach 14 years ago, and 10 years we decided to go on just with the geistig. We did a huge study, over 440 cases with the open healing approach that is going to be published soon, part of it. And in the last year, geistig decided to let's say officially announce that their products are also can also be used in our flapless open healing approach. So we basically will be able to have this study published, and also geistig already recognized that we can use it in this manner.
Okay. The next question. Sorry, I just switched to my presentation because there's a lot of questions regarding the connection.
Yeah, it was a nice picture with me skiing this year, and
the last one you did. Oh, sorry.
No, I was joking. No, it's okay.
I kind of sorry. There's some technical issues. Because. 1 second. Yeah, so the next question, I ask you the next question is regarding how is it possible, the milling, how is it possible to go directly on the implant connection with zirconia? Is there no destroying of the implant in a connection, which I think I have to answer. This is really the interesting part of this inner connection, as I said in the beginning of our presentation. There is we tested this connection a long time already, and we have a lot of amazing experience made, and with studies from the university in Zurich and also with the university in Munich, and I think this is really, I don't know why I cannot change.
Leave it as it is. It's okay. Don't worry.
And so the inner connection we designed really on the the know-how and the material know-how of zirconia on results, because this person was asking this question on results which were done years before. As our name says, through research innovative, we made a lot of research. We designed this inner connection. We designed not a flat base, as the question was. We designed a 20 degrees angulated base into the inner connection, so stable for the zirconia and also really stable from the power onto and into the implant. And as I said, in the 18th of June, and I really try again to switch to my computer. Maybe I have to change. The software is not reacting right now anymore. That's weird. Cannot do anything. Something is wrong here. Let me just answer the next questions or go to the next questions, because I not even can open. I think the software does not react anymore. That's a little bit of pity. Maybe you can switch to Alex again, because I cannot do anything here anymore. Alex, we switch you for a moderator. Now it seems to work.
I switched you as a moderator from my side.
No, thank you. Yeah, this works now. So let me continue. I'm sorry for these technical problems here right now. There was a question from Georgios. So it is a very important question. How is it possible? Can any dental technician in this world mill this inner connection? Here it's absolutely clear, and I already explained this also at the very beginning. It's clear this is in combination, that works in combination with a so-called milling strategy. So it is absolutely necessary that the dental technician who is milling this matrix connection has to fulfill certain testings or certain certifications which we created for this milling of the matrix connection in this perfect fitting. So when a dental technician wants to mill this inner connection, he has to be in contact with us. We will work out a training program for this, and then it is necessary to mill a testing milling, and we implement on the milling machines, and in the milling software we implement a milling strategy. Makes it very easily, as I said, with random milling machine, very easily to mill this connection perfectly. But yes, it is necessary that the mill has to be done by a certificated milling center or dental laboratory, or even a chairside milling machine with the certain strategies implemented in the system.
So just let me complete a little bit, because from what you explained, it looks very, very difficult, but it is not. I mean, it's just a matter of having the specialist from TRI in contact with a person in the milling center or the dental technician, and it's a matter of let's say a few hours all together to put everything side by side.
Exactly, this is right. This is absolutely right. It's just important that we don't mill this just by an STL file. We mill it with a certain milling strategy, which has to be implemented by our specialists, and then that works absolutely perfectly. Then there was a question, I think also from Germany. A very impressive lecture. Thank you very much, Alecsandru. What is the magic behind the connection? Why is it more stable than old school flat on flat connections? First of all, I think flat on flat connection. This is really something where we had in the past some micro gap problems as well. And here again, we designed this inner connection with all the circumstance of newer material like zirconia, and also the CAD/CAM technologies. So we use drilling technologies, CAD/CAM technologies. So we have had to design the inner connection based on these technologies, and it's not a flat, and you are right, a flat on flat connection has a very strong stability, or especially for zirconia, and we created with this inner connect, it's going into internal. I answered it before already. It is a very flat base, but it's not horizontal flat. It has a 20-degree angulation, and so we have physically the absolute perfect stability. And again, here we made a huge study with the University in Munich, and also in Zurich we make a very huge study, which are finished right now, but we will have the official announcement of this study results, which are quite amazing, and stability wise we will have them on our special event on the 18th of June. This was really the very first time that a doctor, Alecsandru Ionescu in this case, showed really the first cases on the matrix connection. And so I think I will look through the questions again and see if there's some surgical questions. Anyways, the questions we could not answer right now live, we will answer later on. We will send you an email from TRI, or we pass the questions to Alex if they're surgical wise, and to answer your questions even after this.
Let me also give a short answer about this question. We will be able to see a clinical comparison in at least 3, 4, 5 years, and we will be able to have a discussion in terms of the stability from a clinical point of view, of course, as we use the product. But from all the preliminary data, we are at least in the same advantages that we had with the original tissue level implant with a crown cemented, but it is not cemented any longer. So we basically eliminate the risk of the cement. We maintain the biological width, and we have improved the let's say aesthetic outcome due to the possibility and the flexibility of the emergency profile. But the honest answer I will give you, hopefully to be healthy until then, in 5-year times, I think, I hope.
Yeah, it's really a pity, because there's really a technical problem. We tried now a few times to change the rights from screen to screen. We cannot arrange that either you or me are moderator again, and so I cannot open the questions anymore. I'm very sorry, because I really wanted to introduce you also to our special event on the 18th of June. I really let me try again. Maybe you can try again, Alex, to give me the rights, but I saw or I get the information that I cannot, nobody can see my screen, either yours or mine, because I really would like to introduce you to this special event. And so in this moment I do that like this. All your questions to this matrix connection, let me try again here. Is it now showing my screen? No, I don't think so. Something is wrong. So all your questions to the special event, which is taking place on the 18th of June this year. It will be an online event due to the Corona situation. We have a full online event. We have some on-site guests, as you, Alecsandru, in Zurich here, in a really beautiful place in a studio. We have guests like Professor Ronny Jung from the University in Zurich, who is going to speak there. We have Linkevicius from who is talking about his zero bone concept in this event, and there's much more speakers, as you will be one speaker here. We have Ramon Gomez Meda from Spain as well, and this is a really great program. So please take the chance and go on our homepage, the TRI homepage, the website, and sign up for this event. Again, I'm super sorry that this technically didn't work out. I don't know what's wrong to show you more slides here. But I would like to thank you again. We will answer the last questions on per email, via email for the audience here. Thank you very much, Alecsandru, for your time and this outstanding presentation. Thank you very much.
Thank you. Thank you, everyone. Goodbye.
Bye.